Good morning, and welcome to the HQI Stopping Sepsis in Virginia Hospitals and Nursing Home conference call. My name is Zanera, and I'll be your operator for today's call. At this time, all participants are in listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Ms. Deb Smith. Ms. Smith, you may begin.
Thank you. And good morning, everybody. Thank you very much for taking the time to join our call today. Today's actually the quarterly data sharing call where we bring the hospitals and the nursing homes together for the call. So this is a great opportunity for us to have discussion among each other than just getting the data reported to us. There'll be a number of times throughout this webinar that you're going to have a chance to ask questions and join in the discussion, and the operator will cue you in at that time. But just remember that you can always use the chat box. We have Candy Hamner, who's the lead for this work in Maryland, and she is monitoring chat today, so any of your questions that you put in chat can also be part of our discussion. Our objectives today, of course, are the data review, some best practice sharing, the box updates, and project updates for the nursing home and the hospital. As always, I like to show this picture of our happy, smiling team. So I'm Deb Smith. I'm the improvement consultant leading this work in Virginia. Candy Hamner is the improvement consultant leading this work in Maryland, and we're the HQI staff. And then for the Virginia Hospital and Healthcare Association, VHHA, we have Betsy Cole-Archer and Wanda Clevenger. They are doing all of the hospital work, the TA, and working with the hospital. So we're going to get right into it. As we all know, we can't improve what we don't measure, and it's really important to keep up with your data reporting so that we can have awesome reports like this from our Jennifer Chang, who is the analyst for HQI. So Jennifer, I'm going to turn the floor over to you.
Thanks, Deb. So we most recently ran quarterly data for our participating hospitals and nursing homes through Q3 of 2016, and these reports were sent to each individual recruited facility on around March 24th. So today we'll be going over the aggregated data for our review. And up on your screen now, we put up a reminder of the measures provided in both the baseline and the quarterly report. For hospitals, this includes mortality, admission, and readmission rates, and for nursing homes, this includes admissions, ED visits, readmissions, and mortality rates for the patients sent from the nursing homes to the hospitals. So we'll be starting the review with the hospital measure. Next slide, please. Hopefully by now, y'all are familiar with the format of these reports, where here the navy blue line represents the aggregated recruited facilities, and the pale yellow area represents the aggregated statewide facilities. So for this first hospital measure, all sepsis mortality, we're finding a year-end rate in that light blue column on the right there of 14.59, and this is the time frame ending in Q3 of 2016. And that's actually just slightly down from our baseline rate in 2015, where we had a rate of 14.68. So it's a slight downward trend, but it's still there. So you can see this is coming from a total of about 2,856 deaths related to all sepsis during this time period. And our network rates are just slightly hovering above the statewide rates by about 1%. Next slide, please. Similar to the all sepsis mortality, when we look at the mortality rates for specifically just the subset of patients that had severe sepsis or septic shock, the rate, again, is slightly down from the baseline. So it comes in at 25.64 compared to 26.25 in the baseline. And our network rates are, again, consistently around 1% higher than the statewide averages. And comparing the deaths we looked at in the previous slide to this one, we find that there were 2,129 in this year-long time frame, which comes out to about 75% of the deaths due to sepsis, specifically due to severe sepsis or septic shock. So 3 in 4 of those patients that result in death are due to severe sepsis or septic shock. It looks like the most occurring in Q1 of 2016. Next slide, please. This next measure is our sepsis admission measure, and rates have again fallen just a little bit from 11.96 in the baseline to 11.81 currently of admissions to reputed hospitals with sepsis. So the participating hospitals rate, again here, are consistently a little higher than the statewide hospital rates, just slightly by around 0.25%, and in both cases making a slight dip in the second quarter of 2016. And kind of interestingly, when we look back at the baseline time frame, there was that same dip also in quarter 2 of 2015. So something about that, those months between April and June. Next slide, please. Finally, in looking at the sepsis and readmission rates, the current rate at 19.46, again, we see a drop from the baseline rate of 20.06, though that still kind of hovers at around 1 in 5 patients with sepsis readmitting within 30 days. So that comparison between the participating and statewide hospitals here fluctuates a bit more from quarter to quarter, as you can see, but overall, it is the one measure where our network rates come out to be actually slightly lower than the state compared to the other measures where we were always a little bit higher. So across the board for hospitals, though, even if they're slight, we have seen declines in rates since the baseline time frame, which is great. Next slide, please. So moving on to the nursing home review portion, we can see that for this first measure, looking at admissions to hospitals from nursing homes with sepsis, that the participating SNF rate is just hovering around the same level as the statewide SNF rate. And in case from the hospital measures, we're actually finding a slight increase from the baseline here. It was up from 26.33 in 2015 to a current rate of 27.25. This particular measure, though, has been a bit controversial because we found that in certain cases when the SNF may not be equipped to treat sepsis, the patient should be sent to the hospital. But we'll continue to monitor progress in this measure despite its complexity. Next slide, please. The next measure for patients transferring from the SNF to the emergency department here looks to be about the same compared to the baseline, with a rate of 4.51 this past year, while the baseline was 4.53, so just about the same. We did note, though, that there was an increase in the statewide rates. However, their baseline was also 4.53, kind of funny that's identical, but the rate jumped up over 1% to 5.68 most recently. So while our network rates stayed about the same, the statewide rates seemed to increase. And overall, the numbers are so small here for this particular measure that the rates tend to look more erratic. If you look at the actual table, our range is running as low as 2 emergency department visits in a given quarter across all of our hospitals to 6 from participating hospitals. And as a reminder, when we're talking about emergency department visits, it's ED visits only, so if it resulted in an admission, it counts towards an admission. So this is only looking at those patients that went to the ED visit and did not get admitted. Next slide, please. For our next measure, readmission rates are actually much lower here, with 21.95% of the discharges with sepsis to nursing homes readmitting, compared to our baseline was 24.6%. So this brings the sepsis readmission rate from nursing homes much closer to the sepsis readmission rate from any setting. So if you recall, that was kind of one of our hospital measures where we looked at just overall sepsis readmission rate from any setting, and that came in at 19.46%. So it looks like our network is moving kind of closer to the all-setting rate. And our participating nursing home rate has also fallen below the statewide rate here, which is currently at 24.22. Next slide, please. The last measure we look at is sepsis mortality, which unfortunately most recently has spiked up to 24.11 from 19.52 in the baseline. So that kind of brings it from 1 in 5 patients sent from nursing homes to hospitals, resulting in deaths to closer to 1 in 4. So whereas our participating nursing homes rate was previously lower than the statewide benchmark, it's now a little higher, with particularly high rates in quarters 1 and 2 of 2016. So that kind of concludes our data review for our 4 measures for both hospitals and nursing homes. And I did want to let you all know that we have just recently received Q4 data within the last week or so. So just keep an eye out for those reports in your box accounts. They should be coming in within the next couple of weeks. So by the beginning of May, you should receive the last quarter to round out 2016. And that kind of concludes our data review. So if there are any questions about the data, operator, could you please open the line for questions?
Absolutely. Thank you. We will now begin the audio question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. Waiting on standby for questions.
Thank you, Jennifer. This is Deb. And I want to just remind everybody on the phone that this is your chance to speak with Jennifer, to have any of these rates and data explained in more detail, or to ask questions about what her thoughts are with some of these changes.
I'm not showing any questions at this time. Oh, well, I do have one question. Just a moment. Abdul Khanat, your line is open.
Yes.
Please go ahead.
Okay, hi. My name is Abdul. I'm the Director of Nursing at the Jefferson. I have the email that they sent me a couple of weeks ago to try to register for the inbox. And I've tried and I was not able to register. So I'm not able to put in my data or participate in the data collection at this point right now.
Go ahead.
I was just going to say, it might have expired, is that right, Deb? So we might have to resend the invite, but it might just be something where you have to have your IT department allow for the box website. I don't know, Deb, you want to clarify further there? I think other people have had similar problems.
Yes, Bill, thank you for joining us today and asking the question. I will send you out another invite this week, and then if it still doesn't work, we'll have to have you work with your IT department at your facility. Is there anybody else on the line? We'll just take a couple minutes right now since the question was asked. Anybody on the line that can speak to having to have your IT department allow access to Box? So, operator, is there anybody queuing in?
I'm not showing any questions at this time.
I know there have been nursing homes who have had to work with their IT department. It's just a matter of allowing that website, like any other one that you need. It's the firewall preventing it from accessing it. But Abdul, I'm imagining that you would like to have access to this data, though, correct?
Yes, I would like to have access. Yes.
So being that you're seeing it for the first time, do you have any questions right now, or?
No, not quite yet.
Okay. And then, of course, within your box files, you're going to be seeing your facility's data along with disaggregated data.
Okay.
So any other questions or anybody that wants to help Abdul out here?
I'm showing a question from Mr. Brock Baker. Your line is open. Please go ahead.
Hi, Brock. Hello?
Your line is open.
Can you hear me?
Yes, now we can. Thank you.
How are you?
Good. How are you?
Good. Two things. Sometimes using a different browser for other than Internet Explorer will allow people to view these things, Chrome as an example. But the real question I have is the data that is being reported, we have yet to be asked to submit data, so where is this data actually being accumulated from?
I'll let Jennifer speak to where this data is coming from.
Sure. So, what's your facility? Sorry.
Portsmouth, Autumn Care Portsmouth.
Autumn Care Portsmouth. Okay. I'm sorry, we kind of had a mishap with a couple of the facilities, including yours, but we most recently dropped the self-reporting template in your box account. So in addition to the template, you should also find instructions there, and that was just done yesterday. So I don't know if you've gotten a chance to take a look at your box account. But there we have the self-reporting on more of the process measures, and then this data that we're reporting on currently is pulled from the claims. So that's something that we pull from the Part A claims, and then we'll be asking you all to report some of the data from your own facility into that template.
I somehow missed it, so I'll take a look. Thank you.
Sure.
I'm not showing any further questions.
All right. Well, Jennifer, thank you very much. And Jennifer will be, she has another slide to talk to us about, but she'll be hanging in there for the rest of the webinar also. So if you think of something later when we open up the lines, please feel free to ask her then. So Jennifer, I'll turn this over to you and then to Wanda for the next couple slides.
Sure. And I did want to just also address, so for Abdul, we will be sharing this aggregate data. In the meantime, if you still are having trouble accessing your box account, and we can actually send you the supplemental information page, which kind of explains these measures in more detail, since we didn't have that in the slides here. So hopefully that might answer any questions you might have coming up, but otherwise, please just direct them to our team. So still on data here, this next slide is a slightly separate note. We ran an additional correlation analysis following some team members' observation of an emerging pattern that seemed to indicate an inverse relationship between sepsis mortality and sepsis present on admission rate. So we calculated the sepsis present on admission rate and all sepsis mortality rate for all the hospitals in Virginia. And on the scatter plot here, you'll see that each point represents a hospital, and that the higher the present on admission rate, we seem to see a pattern of a lower mortality rate. So statistically, you'll see on there that there's an R value of 0.43 or an R squared value of 0.18, which indicates that 18% of the variation in all sepsis mortality can be attributed to the sepsis present on admission rate. And now I'm going to turn the floor over to Wanda, who's kind of going to discuss how this further reinforces the need for early identification in sepsis as a key to survival.
Great. Thank you so much, Jennifer. I appreciate your doing that analysis and also with this work, just bringing attention to the present on admission issue, because we have a wonderful opportunity with this project, working with hospitals and nursing homes to look at how from the nursing home information can be provided to the hospital and vice versa, with the overall goal of improving care of our patients. Next slide, Deb. So just on that same line of present on admission, this chart just plots for each hospital participating in the this project their present on admission percent of patients. So you can see there's quite a range from 5% all the way up to above 20%. The statewide average is about 11% for present on admission, so you could see the performance variation between hospitals. And we're going to talk a little bit about that now. Can you go to the next slide, Deb? So from a recent paper looking at mortality and early sepsis diagnosis, you can see in this chart the blue bars, which represent the present on admission mortality rates, and then the red bars represent the not present on admission. And so even in severe sepsis and septic shock, you can see with earlier diagnosis and identification the improvement in outcomes for the patients through a lower mortality rate. And so keeping that in mind, how do you achieve earlier diagnosis when there's no simple test, and some of the symptoms through identifying sepsis or the state of an infection can be somewhat vague. Next slide, please. So further reinforcing the notion of early diagnosis, From the CDC vital signs report, we see confirmation again that sepsis begins outside of the hospital for nearly 80% of patients. And how do you identify some of those patients that may be at high risk? Those patients in nursing homes with chronic disease would certainly be in that category of being at high risk for sepsis. But the CDC reports that 7 to 10 patients, or 7 in 10 patients with sepsis had recently interacted with a healthcare provider. The vital signs report also encourages early identification in order to have better outcomes. And so we're going to talk about that as a change idea. Next slide, please. So the change idea is that there needs to be greater emphasis on public awareness, and also that health providers need to obtain more information about what is happening to patients hospitalized for or with sepsis before they are admitted, and if they survive after they are discharged. Next slide, please. So thinking about the disease timeline and the progression of a disease, you can see from this kind of simple illustration that the onset of symptoms, which is in the center of that chart, when you look to what's on your left, the pathologic changes and what they call the subclinical disease. And that's where you'll start seeing some of those early symptoms before you see the full onset of symptoms and the diagnosis, which follows shortly thereafter. But at that point, in terms of the diagnosis, depending upon what stage of the disease you are at, that can make a difference in terms of a person's survival, catching it earlier or catching it later, where, as we know with sepsis, the mortality rates are very high. Next slide, please. So one consideration for you is looking at the stop and watch form that's part of the Interact tools. This is an innovation project that we're working on, working to identify opportunities between the two different settings, the hospital and the nursing home. So this form is something that's used in the nursing home setting, and it is something that is used to help communicate between the RN and the CNA. The language in the form is very simple, and it's used to help the CNA provide information to the nurse about some subtle changes that may be taking place in a resident. So in the hospital setting, thinking about this form and how it's used, I would ask hospitals that are on the line today to think about how can this tool be used to gather information from family members or visitors on their patients, either presenting to the emergency department or that may be on a unit. Now, because this form isn't typically used in hospitals, there's usually a process that hospitals need to go through. So I would recommend that you bring this form to your sepsis committee and get some input on the language. Again, the language is very important because it is not complicated language, and yet it will allow family members who may not know all of the clinical lingo to be able to communicate some important issues to their nurse or physician in a way that's consistent. And again, using it in the emergency department to hand to a visitor or family member who's accompanying someone who's being admitted, or if the patient is able to ask provide the form to the patient, him or herself, to see if any of these symptoms may have occurred. Now, these symptoms are not directly associated with sepsis. However, they do point to the symptoms that are captured in those, some of the information around an infection or subclinical signs of an infection. So it would be important to identify or flag some high-risk patients. So after reviewing this form with your sepsis committee, I would recommend bringing it to your hospital's Person and Family Advisory Council, again, for review and input on whether they feel this would be of value and worthwhile to pilot at your organization. And so I do hope that hospitals will consider using this form, and importantly, because it's used in the nursing home setting, for those patients that are coming from the nursing home, again, it gives a common language. If you're calling the nursing home for follow-up or trying to get more information, it may provide that vehicle for common sharing and hopefully better care for the patients. There is Catherine on the line, who is from a nursing home, and they are using the Interact form and Stop and Watch. And Catherine, would you like to share some of your experience with this form?
We definitely utilize the Stop and Watch tool here. It's a good communication tool between the nurses and the CNAs. The CNAs do spend a good portion of time with the residents, and a lot of the time the CNA is one of the first ones to notice something's just not quite right with the resident. So they do utilize this tool. They're able to go in. The format's really easy for them to pick and choose, which one applies to their resident, and it flags for the nurse to go in and further assess and see what's going on with the resident. So it's a useful tool.
Thank you. Okay, next slide, Deb. So on this issue of early diagnosis and screening, I've just included some measures that hospitals may want to consider when thinking about looking at their process for screening for sepsis, as well as the time of diagnosis of sepsis. And so in the ED department, number of staff compliant with the sepsis screening, and then number of screenings performed on all potentially affected, seriously ill, hospitalized patients. And then looking at the percent of patients identified with sepsis or septic shock within 2 hours of admission to the ED, and then the percent of patients who have sepsis that are identified after they're admitted. And I do think number 3 and 4 are really important as we're doing this work, looking at that cross-setting care if there's opportunities to improve on any gaps that we may identify through this process. Next slide. Another recommendation that was identified subsequent to some site visits to hospitals that I've been making is the creation of a sepsis log, and to report this information at your hospital's morning huddle. The scope of managing sepsis is quite broad, and I don't know if leadership is always aware of the number of sepsis cases in-house or the work that's identified just supporting staff on diagnosing and identifying patients at risk. So again, just some simple measures that you may want to consider including in your hospital's morning huddle or even your unit huddles. The number of sepsis patients present on admission, sepsis cases identified post-admission, and then the number of rapid response for sepsis. Or some facilities do have an EICU, and they are using the EICU for providing support to nurses on symptoms related to sepsis and next steps. Next slide, please. So just a couple of hospital updates for this project. If you have not scheduled your hospital site visit, please send me an email or use the survey link suggesting to provide me with some available dates. I will be sending out a reminder email to those hospitals that I haven't heard from yet. So you'll see something from me in your inbox within the next day or two. We talked a little bit about the box folder when Jennifer was doing the presentation, but just a reminder to hospitals that you need to go into the box folder to update your performance measure data template. Every hospital has a folder, and I do have a list from Deb for those hospitals that have not accepted their invitation. So again, we'll be doing some follow-up with those. I also had some requests from hospitals to add individuals to your to give access to your hospital box folder, and I'll be following up with Deb on those requests for invitations this afternoon. So again, you should hear sometime this week on those issues. The next hospital Stopping Sepsis webinar will be on Tuesday, May 16th. Kathleen Bowman will be joining that webinar, and the focus will be on screening. So we'll cover a lot of issues, a lot of clinical issues with the screening from Kathleen's experience. So please note that date, and I'll be sending out an invitation shortly. Another resource for you is Stopping Sepsis webpage will be added to the VHHA's Center for Healthcare Excellence website. And so there I will be posting information on best practices, just updates on the project and other resources, and some shared resources from other hospitals. And I think it'll be a good space for not only updates but also collaboration. And that's all the information I have, and Deb, I'll pass it back to you.
Thank you, Wanda. Operator, can you open up the lines, or not open up the lines, but let everybody know how they can ask questions? I'd like to get some discussion going with this slide that's currently up, but also if there's any questions about what Wanda has just talked about, and or any questions that you've thought of for Jennifer.
Absolutely. Thank you. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset first. Once again, if you have a question, please press star then 1 on your touch-tone phone. Waiting on standby for questions.
Yes, right, thank you, Operator. I wanted to just make sure, I'm sorry, am I getting feedback or is someone trying to ask a question?
Deb, it's Candy. I wanted to make a comment on one of the things that Wanda had.
Okay.
And it was just, I was on a seminar recently where a hospital had done a study of their mortality rates looking at present on admission and then those patients who were identified on the med-surg unit. And they found that their mortality rates for the patients identified to have sepsis on a med-surg unit, they weren't admitted with it, present on admission, was much higher than those that they identified when they were in the ED. And they found that they were having issues identifying somebody in that early stages of sepsis on their med-surg units. And I think that's kind of consistent with what Wanda was speaking about. I'll see if I can find any information on that and send it to Wanda.
That would be great, Candy. Thank you so much. One recommendation that came out of site visits when I've been talking about this, the correlation between the present on admission and the identified in hospital, is that for those patients that are identified in hospital, that a recommendation is to have the nurse on the unit, maybe your sepsis champion on the unit, do a review or a look back on that case to see if there were any signs, subtle signs that may have been missed, because it's an opportunity not only for that nurse to learn more about the process, but for your whole team to learn of some of those subtle symptoms that you may have missed, or something in your process that may have made it a little easier to look over something. So I think it's a great opportunity to look back, learn, share the information, and just really build your bench of sepsis awareness on your units.
Thank you. And if we do find that resource, Candy, I'm sure we can send that out to everybody that's on the line too.
It's a recent webinar, so I'll get it for you.
Great. Thank you.
Do we have any questions in queue, operator?
I'm not showing any questions at this time.
Okay, so I just wanted to make sure that everyone, all of the nursing homes who are on the line now, and then of course the ones who are not present today, make sure that you've received your packet of tools in the mail, and those are the Seeing Sepsis 100 tools. If there is anybody on the line who'd like to talk about how you're using those tools, we'd love to hear that. And also, if you have any comments or suggestions or changes to those tools or additional tools that you would like to see us develop during this project, we're always open to that communication. But for right now, I did ask Katie Pace from Stanleytown to join us on this call today because her facility has incorporated some of the Interact tools into their daily practice. So let's bring Katie on, and then any questions or comments or conversations. I mean, Katie's happy to answer some questions also to get y'all going. So, Katie?
I'm here. So we definitely use our SBAR, the Interact form, along with our Interact transfer form. So if we have a patient here that has a change in condition, we do utilize the SBAR form. We go through, fill out all of the information before we call our physician. That way we've kind of got all of our thoughts collected because, you know, when you call physicians a lot of the time, it's they kind of rush you off the line. So that way you've got all of your stuff prioritized and the points that you want to get across and the information that you want to relay. So with the SBAR form, you're going to be entering in your most recent set of vital signs. So in regards to the sepsis, you would be noting if you've got a temperature greater than 100, your heart rate greater than 100, your systolic blood pressure less than 100, stuff like that. So again, when you're entering that stuff in, it can help, you know, you to think about what's going on with your resident. That way when you talk to the physician, if you think it might be sepsis, you could relay that information. And they might decide that they want to send them out. If they do, we would also then fill out our Interact transfer form. If they decided that they did want to treat them in-house, there's some things that they might could do here, like some lab work, stuff like that. I've got our SDC here with us, and she was just going to go over some of the things that we do in-house if we're keeping them here.
Awesome.
Okay, so some lab work that we may draw. You could do a CBC with DIF, a lactate level. You could do a urine analysis or a urine culture, some blood cultures, and they could put in the IV and do some IV fluids and administer IV, PO, or IM antibiotics. So. And then in addition to that, you know, if we are treating them in-house, we would be monitoring, assessing them for worsening of their condition. So if they had a decreased urine output or if their systolic blood pressure keeps dropping, even though you're giving them IV fluids, or if they have altered mental status or anything like that, again, we would call and notify the physician and see which route he wanted to go, if he wanted to send them out.
Thank you. This is Deb again. So I'm curious if there's anybody on the line that has any questions, especially those hospitals that are on the line, any questions that you have for this nursing home, which you have the ability, Katie, to do all of this at your nursing home, correct? Like the IV fluids, starting antibiotics, doing these labs. You're able to do this in-house at your nursing home, correct?
Correct. We do have an iStat machine available for us that we can utilize, and then we also have the lab that comes in and is able to do stat labs for us. Along with that, we also have dynamic mobile imaging that can come in and do stat x-rays and things like that.
And then that transfer form that you're filling out, what happens with that?
We print that off and we send it with the patient to the hospital. That way they can utilize the information that we've already collected.
Perfect. Thank you. So is there any hospitals on the line that want to weigh in also?
Once again, if you have a question, please press star, then 1 on your touch-tone phone. Kyle Allen's on the line.
Hello, I do have a comment.
Your line is open.
Yeah, can you hear me?
Yes.
This is more of a comment. and maybe secondary scope of the project, one of the things I get concerned a little bit about, and I'm a geriatrician and work on both sides of both acute and long-term care, is the kind of over-medicalization of patients. And so I think one of the aspects is being able, I was the person to put the question in about advanced directives, because I think that's a quality issue. That if people actually, particularly long-term care patients who haven't had that discussion, just because we can treat sepsis doesn't necessarily mean we should. That makes kind of catch people off guard, because we need to really make sure we know what the patients want in the context of all of their chronic illnesses and their trajectory. And so I think one of the things that I get concerned about this project without actually having something to kind of measure either in mortality review or that type of thing, are we appropriately treating folks? Or was it just, it's kind of like the surgery was a success but the patient died? Are we successful at treating sepsis, but was that really the right approach and outcome for folks? Nothing that's been presented here. I think there's still room for improvement. I think the Interact programs, the Stop and Watch, and all those kind of things are really appropriate. Hand washing, all those things are appropriate. But I think doing this project was actually in parallel or something to be able to look at appropriate treatment in the context of the person and their wishes. And did we do the right thing about having those discussions? And I think we can push ourselves much further along with this project. Maybe it's out of scope of the specific project, but having a parallel project that looks at that kind of measurement and outcome.
Yeah, I definitely agree. We need to know what way we're going with this treatment. Does the patient need to be made comfort care, or do we need to escalate the treatment? So we definitely try to look at that, and if the nurse feels like, the patient really would benefit from comfort measures, we try to advocate and have those tough discussions with the family about their prognosis and, their quality of life. So.
This is Deb. I'm sorry, I didn't catch the physician's name, the geriatrician. What is your name and where are you from?
I'm Dr. Kyle Allen. I'm the Vice President for Clinical Integration at Riverside Health System and Medical Director for the Division of Lifelong Health at Riverside.
Awesome. Thank you. So glad you joined us and that, we've got your voice on the line too. Have you seen the tools that we did send out for this project?
Yes, I've been keeping up. I was kind of getting more about kind of really focusing on and I'm really very happy about looking at the data, know where you're at before you know where you're going. But I think in addition to that data, we've got to figure out somehow how to measure that process or quality outcome about appropriate advanced directives in this population, particularly on the long-term care side. That's all I'm saying.
Yeah, no, thank you. Thank you for that observation. And
can I speak on this? This is Candy. I just wanted to, because of the Maryland project is much further along, the same questions come up a lot for us. One of the tools, we really do stress actually in the webinars and as you get through the education, the need to know the residents' wishes immediately and getting that documented, and that the algorithms and all actually show treatment that can be done in the facility itself. But I think you bring up a really good point that we don't have a way to measure it. It's not in the scope of this project, but maybe something we begin to think about. I mean, it's really a good question.
It's really a phase 2 type of thing, and I think without that measurement, then we're not accountable to it, right? And we're focusing on an outcome that on one level may be good, but in the context of the person or the patient, that type of thing may not be. Mm-hmm. So it's kind of like the disease with the patient versus the patient with the disease. And so I think being able to, from a performance improvement piece, and I understand about performance improvement and scope, but I think not having some kind of focus at that. I know it's in the education materials and that type of thing, but the work that's needed around advanced and serious illness care and those advanced directives is significant. and it's an opportunity.
Yes.
That's what I'm saying. It's great work.
Yes.
Can we use this as an opportunity to also drive what's critically important in quality improvement and safety?
Thank you.
Very good.
So, is there any more discussion about the tools or Interact? Katie, I'm so appreciative that you joined us today. It's very interesting.
Thanks for having me.
Yeah, from your point of view. Anybody else have any questions, comments?
Once again, if you have a question, please press star then 1 on your touch-tone phone.
All right, no further questions?
I'm not showing any further questions at this time.
Okay, well, you all know that you can put it in chat at any time. But great discussion that we just had. So I just want to go on and make sure this is a screenshot of the self-reporting template for the self-reporting data. This one just happens to be for the nursing home, but there's another one that's for the hospital also. Just as a reminder, we should be entering data monthly using this template after you've been able to access your box account. So right now we're looking for January and February data that should be entered in there. If you have March's already also, please get that in there. But we're noticing that it's about 30 plus days behind with the way that you're able to collect your data. So we're hoping to have March data in there by May 1st, and we'd have that first quarter of self-reported data. Anybody who is having trouble accessing it, we do have our contact information further in this presentation. Please feel free to contact us to get yourselves going with it. And the self-reporting data, those instructions are already in your box folder, so once you do get access to Box, you'll see that the instructions are there along with the template. And for the first time that you're going through it, you might just, have some issues and have to print it off and go through it and watch each and every screenshot, making sure that you're doing it. But once you get it going, it should be pretty easy to do. And just remember the reason that we're using this is because this is a secure file transfer for all of this data. And that being said, I wanted to recognize those hospitals and nursing homes who have already accessed their box accounts and folders. So if you don't see your name on this list here, please reach out to us. We're going to be sending out those invitations to Box once again this week. Once you get it, you need to address it as soon as you can because that invitation does expire within 10 days. So if you have an invitation from before, an email from us to join Box, you can't use it anymore because it's been greater than 2 weeks, actually, since that last one was sent out. So all of these hospitals on this list have already accessed their box folders, and then the ones that are golden, the highlighted golden hospitals, are the ones who have successfully reported their self-reported data using the template in Box. Is there anybody from any of these hospitals on the line today that would like to talk about the process, just to support it for those who haven't used it yet? And just remember, you can hit *1 to get in the queue. Or you can use the chat. So we'll move down to the nursing homes. This is a list of the nursing homes who have accessed their Box accounts and been successful at getting into Box and have at least gotten in it. And we do have 2 nursing homes also who have successfully self-reported their data using that template in Box. And if there's anybody on the line from Riverside Hampton or Carriage Hill Health and Rehab, we'd love to hear from you about how this process has worked. Operator, can you let us know how to get back into the queue in case there's someone from these facilities?
Absolutely. If you have a question or a comment, please press star then 0 on your touch-tone phone. I'm sorry, star then 1 on your touch-tone phone. You may need to pick up the handset first if you are using a speakerphone. Once again, if you have a question or comment, please press star then 1 on your touch-tone phone. Waiting on standby for questions or comments.
I know I talked with both of these facilities, Carriage Hill and Riverside Hampton, and they were not going to be able to be on the call today, which was unfortunate because I would really like to hear from them. So maybe on our sharing call next month. But congratulations to all of these.
We have a question from Ms. Lauren Leska. Lauren, your line is open. Please go ahead.
Hi, Lauren.
Hi, this is Lauren Leska from Southside Regional Medical Center, and we've been using the Box self-reporter for a couple months now, and it's going very well, very easy to use.
So were the instructions spot on, or
we had no problem at all.
So you were able to follow the instructions, and they assisted you with being able to get all of your data in?
Sure, yeah.
And can you speak to the fact that you get instant, kind of like instant gratification with the graphs?
I do. As soon as I hit my number. Put my numbers in and all the data is calculated and the percentages are there. We use that for our medical committee meetings as well, for our PowerPoints, and they seem to like that, how it's displayed with that Excel sheet. So far so good.
Thank you. That's awesome. And that template, of course, was developed by Jennifer Chang, who you heard from earlier. And it is nice because as soon as you put your data in, you're not waiting for anybody to create a report.
Right.
Does anybody have any questions? Well, thank you. Thank you for sharing that. It's always good to hear. Anybody else in queue, operator?
I'm not showing any further questions or comments at this time.
Okay. So here is our contact information. If you do have trouble just accessing your Box, you have the option to speak with Sarah Helen Studebaker, who is project coordinator at HQI. She can help you get into Box, and sometimes you may get the invitation from Sarah Helen too. If you have any questions about the hospital data reporting, you can talk to Rhonda Clevenger. And if you have any questions about the nursing home reporting, you can talk to me. So we have our phone numbers there. We have our emails there. We are a phone call or email away. So I'd just like to go over a few things for the nursing homes. Make sure that your facility has Box access, which I said before, we're going to be sending out those invitations again this week, and then following up to get everybody into Box. And then complete your self-reporting template in Box and making sure that you're keeping that monthly reporting current. And also, there was an infection prevention baseline assessment that was sent out. Confirm that your facility has completed that assessment. For next month, our next call, we're not going to have a webinar in May. We're going to have an open sharing call that will replace that webinar. So similar to today when we opened up the lines, we're just going to have a phone call to be able to ask questions, share information, maybe just jump into, what issues you're having with Box, with reporting, and being able to help each other on the line with any of the barriers that we've had to reporting or some of the successes that you've had. So start compiling that list of your questions, because this will be your opportunity to talk to others within the nursing home project. And with that, we'll take any further questions, if there are any on the line, operator.
Thank you. If you have a question, please press star, then 1 on your touch-tone phone. Once again, if you have a question, please press star, then 1 on your touch-tone phone. Waiting on standby for questions.
And Candy, I see that we have another question in chat. Can we cover that real quickly?
I'm sorry, it's not coming up on mine.
Okay, so I have a question from Amanda about, can we get the stop and watch tool separately? And you'd like to take that to your hospital patient family advisory group? That would be awesome. That's a great place for that. So we will send out that link. It's with the rest of the Interact tools. We don't have a stop and watch tool that's branded by HQI, but all of the Interact tools you can use and pull off of the internet. So we'll send that out. Any other questions?
We have no further questions at this time.
All right. Well, thank you, everyone, for joining this webinar today. It's nice to have the hospitals and the nursing homes together. Another thank you to everybody who's taken the time to call in, put in chat, and especially to Stanleytown, Katie and her partner there. Thanks a lot for helping out with this webinar. Everybody have a really wonderful afternoon. Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect. Speakers, please stand by for your post-conference.